All right. Hello, everyone joining us today from across Canada for this amazing presentation on anatomy and danger zones. We are presenting this with Clarion and Dr. Lee Walker. First, I would like to thank Clarion for hosting this amazing presentation. Your dedication to our professional growth and our education is definitely noticed, and you finding the best speakers from across the globe is what makes you a unique partner for us. So I would like to thank Clarion for that. I would like to introduce myself. I am Barb Hemsworth. I'm a nurse injector here in Toronto, Ontario, and I'm the co-owner of Skinworthy with my husband, Dr. Cody Hemsworth. I have been a speaker for Clarion, done various peer-to-peer events, one-on-one trainings and presentations, and my husband and I travel the globe seeking the best education. And this is where we had the chance actually to learn from Dr. Lee Walker in Geneva, Switzerland last year. So I would like to introduce you to Dr. Lee Walker. If you haven't had the chance to hear him speak already as the key opinion leader for Teoxane or with Clarion, you are in for a very educational experience today. So Dr. Lee Walker is the clinical lead educator of Lee Walker Facial Aesthetics Academy in Liverpool. And not only does he bring a wealth of knowledge as a dental surgeon, he has had 19 years plus of experience in non-surgical medical aesthetics. So Dr. Lee Walker participates as part of the ACE panel, or the ACE group, which is the Aesthetic Complications group in the UK. He also sits as the expert advisory panel of Safe Face, which is a body of registered professionals that set industry safety recommendations. So in addition to publishing various expert studies and scientific opinion, he is an active global educator. As the KOL for Teoxane International, he has, and I don't say this lightly, blessed the minds of various practitioners from over 30 countries and 5 continents. So without further ado, I would like to introduce you to Dr. Lee Walker.
Thank you so much, Bob, for the very kind introduction. And once again, thank you to Clarion Medical for the fantastic opportunity to share some education and knowledge with you all this evening. How do I follow that introduction? By having a fantastic moderator. So thank you, Bob. And we're trying to keep this incredibly interactive this evening, and we've got a lot of ground to cover. So we're going to start on what we deem, or what we call, the Teoxane approach, which is the key fundamentals on really what we stand for, the philosophy of Teoxane. And it's based around 3 core principles. What it is not based around is these algorithms and formulas that you see within different companies of a 1, 2, 3 and ABC, or even a do re mi type of approach. That is all of the how, but none of the why. So I'm going to try and help you become a little bit more of a deep thinker and how you fit the pieces together. And more importantly, if we understand anatomy, we can extrapolate our information. We can work backwards to find out how we've caused a complication, or more importantly, how we can manage that complication. So these 3 fundamental pillars on which we are based is anatomy, aging, and assessment. The great thing about Teoxane is we have a plethora of techniques, and you have ownership of your own technique as the professional. We're not going to show you how to inject. We're going to share with you our techniques. And again, we have an incredible portfolio of products available to us with versatility and adaptability for all tissue layers. And what we want to do is sorry, Bob.
So Lee, I want to say, as we move into the presentation on anatomy and safety, we want to keep this really interactive. So if people have questions, please send them into the Q&A box, and I'll be able to ask those questions to you. And then if we don't get to them, we'll go over a Q&A at the end of the presentation. So
perfect.
Questions coming.
Perfect, thank you. Yeah, so be interactive, and as Bob said, put them in the Q&A box. So what we have is that ATP, and it's really these 3 little letters should form how you practice within your daily office. And anatomy will underpin everything that we do. So it's really important that we understand and respect the anatomical principles. We need to understand that the face moves, and that facial dynamic movement is incredibly important for 2 things. 1 is natural and predictable results, and 2 is longevity of your filler. We've also got to look at ethnicity, gender, and age as part of that anatomical aging and assessment. And again, we have to look at the static and dynamic compartments and the importance of this. What we're not going to tell you how to do is how to inject. I can certainly share with you techniques based around how I inject, but again, you have ownership. And we have a cutting edge filler portfolio with an incredible, unique position within the market, being dynamic fillers. But we don't just have dynamic fillers here at Teoxane, we have classically static fillers as well. And what we have to remember is that you have both static and dynamic areas of the face, and we have aging through all of those tissue layers. So it's about how we place the right product in the right places with the right techniques. And why is this important? Well, I'm going to take you back just a little bit in time, well, around about 200 years to be precise. And what this timeline is, it's the evolution of aesthetic medicine, or more importantly, the evolution of new structures which were identified in the face. So around about 200 years ago, Bichet found the buccal fat pad. And up to the year 1999, we found that we had 13 new structures identified. So that took us 200 years to find. And from 1999 to now, we found over 15 new structures. So why this sudden big boom of anatomical structures that we couldn't find in 200 years? It's not down to surgery, it's down to aesthetic medicine and the importance of the great minds. And so what we've seen is not just our anatomical knowledge grow, but also our rheological knowledge. And we've had the evolution with our anatomical findings. Now we need to make a marriage between what we're finding anatomically and what we have in the marketplace. And the 1980s was really the birth of injectable fillers, and we had collagen, Zyplast, those type of things at that stage. And then we had the first HAs on the market around 96 with Galderma. Juvederm, around about 2 decades ago now, brought their Hyalocross Ultra range into the arena, followed pretty quickly by Vicross. 2008 was a mix-up between the Galderma, between Emervel and Restylane, a mismatch, trying to get a very unique property within their portfolio. And then we see nothing. Nothing happened. We had static fillers. We didn't have much of a change until now. And again, this evolution is come with the fourth dimension, dynamic movement. So 2015 was the birth of RHA, a new range of dermal fillers, which were designed to move with the face. 2017 seen a phenomenal achievement for Teoxane, is that the 3 products went through at the same time. And I think that's the first time that's happened in history with 0 compliance. And 2020, just this year, sees the launch in the US of what I would consider the best range of fillers out there. And again, this is taken in a couple of considerations. One is dynamic movement and degradation. But the other key factor is this. How we were trained very early on within our careers was to, especially me, because I'm a lot older than most of the people, what we found is that we had to bury the product. Not because it was safer to do it, because the rheological properties of the filler wouldn't allow us to go superficial, because we'd have tyndall, we'd have palpability, we'd have lumps and bumps, and it didn't look great. So now RHA, we can place so much more superficially. So we have so much more efficiency or surface volume coefficient, and we can also place in areas of lower risk. So why is this so unique? Again, it comes down to the process of how we manufacture. And again, we manufacture this very differently. And we use a pouch, and we very gently agitate under low stressful conditions to maintain the integrity of the HA. And why is that? Well, this is natural HA, and you can see it's long chains, natural entanglements, and held together by covalent bonds. And this gives you that viscoelastic movement within the tissue, and it also maintains the architecture. Classically, cross-link fillers are different. You sacrilegiously take those long chains and you chop them into smaller pieces and glue them together with BDDE. Now, that takes away that movement which you want within the tissue. and it builds rigidity, which is good, which is great in some areas of the face. And it's also good for longevity. What we've evolved into now is biomimicry. So we're making our HA as close to Mother Nature as possible. We're keeping some of those covalent, non-covalent bonds, and we're adding cross-linker to it, again, to allow the structure to move. So this is RHA. You have your natural HA and the RHA, and they look from a microscopic perspective very, very similar. And your traditional filler is your rigid. So RHA is different. And again, why is this different? Again, you've got wonderful people writing wonderful publications for our benefit. And we now know that we have different forces applied through the different tissue layers, all of the target tissue layers, which you're going to target as injectors. And within the superficial layers, you'll have this lateral shear. And then in the deeper layers, you'll have compression. And what I've done, I've made it very easy for you, because I've taken some independent research and we've looked at each target area. We've looked at what forces apply to the filler within those target areas. And then you can select the marriage between the rheological properties and your target tissue zone. And again, it's a very sophisticated, evidence-based approach in how to match your rheology for the tissue planes. Because remember, through the aging process, we're going to age through every single tissue layer. So that's just the Teoxane approach. That's just RHA. That's what I use, and the reasons why I use it is because it matches everything that I want from a filler. I want volumization, projection, integration. I want the tissue to be able to move. So this is the reasons why I use it. So we're going to get into some of the complications. We're going to get into the danger zones, the anatomy now, the sort of the very, what I would call unglamorous side of aesthetics, but it's incredibly important. And where I want to start is with this.
So Lee, I just wanted to preface this presentation again with the poll that we have for our followers today. It has various questions on anatomy, complications, and techniques, and this will help us get into some further questioning at the end. And again, just to keep things interactive. I apologize for interrupting. I just wanted to talk about that poll before.
No, this was going to be my next sleight of hand with the poll. So I've got it, and there we are, straight in front of us. So all of our participants, if you feel free to answer the poll, and it gives us a real flavor of what we're going to go through this evening. And give us an idea of where we need to direct most of this. So you have 2 minutes to answer the questions, and then me and Bob will analyze the results and whether we're going to be surprised or not. Again, it's a very nice way of interacting between us and finding out where we need to focus our attention.
And they're completely anonymous, so we want to make sure that you feel comfortable in answering these. It's just helping us, again, guide questions and discussion.
Yeah, your name, your zip code, and your cell phone won't come up on these. These are completely anonymous, so feel free. There's 10 questions, and we have around about 2 minutes to do that. So we'll give you a couple of minutes, and then we'll look through some of these results. So Bob, did you create these wonderful? Because they're fantastic. They are very pertinent to what we're doing. Very intelligently set out.
I did create them. These are, I think, some common areas that we inject as nurse injectors. Probably some common questions that we have. Maybe some common complications that we're often maybe shy to discuss because we feel judged for them. But I think with having your expertise and being on ACE and seeing so many complications and understanding anatomy the way we do, I thought we would take advantage of the knowledge that you have and ask some things that we might experience in our everyday practice.
Yeah, it's always useful to people call me an expert. I'm not an expert. I'm a person who's made pretty much every mistake and learned from it. So it's getting you to avoid the mistakes I've made, and so you don't tread down the same perilous path that Absolutely. I've done.
I also think it's important to share, maybe to have someone like yourself who has made these mistakes or has seen the mistakes so we can learn from them. It just creates this little catalog in our minds of before we go and inject an area, you can reflect on maybe a story you heard or a colleague's experience in this area, and it might just adjust maybe the way you're thinking and doing things. It's just a little check, because I know sometimes in our everyday practice we get so busy and it's just like patient after patient, but sometimes it's nice to have this little catalog of other colleagues' experiences to help us just reflect before we inject.
I couldn't agree more with that. So we're getting quite a nice feel from where people need to be or where they want to be in respect of complications. So some of them are really interesting, really, especially the first question. I'm quite interested in the temporal fossa area and people's rationale for injecting into that area. So again, we'll just give you a minute more and then we'll have a look.
Yes, I agree about the tempo. I think that conversation back and forth of superficial, deep, superficial, it just keeps going back. And I myself have gone through the going superficially, then injecting deep, and then returning back to superficial based on these types of presentations and expert opinion. But I think it's still like one of the great debates of that temple area and how we go about treating it.
Okay, so I think we'll stop the vote here and we'll have a look through, Barb, okay?
Perfect, thank you.
Okay, so I think we've almost 50-50 really between a deep and superficial injection in the temple, which we'll get to a little bit further. I'd like to see this number 78% drop down a lot after I've discussed the piriform fossa, because I'm going to discuss that area in a little while. Lateral, again, maybe there's going to be a shift in people's technique for the lateral cheek based on the pertinent anatomy with it. Lip technique, yeah, I was expecting those numbers. And again, maybe we need to shift a third of people over onto the superficial plane. Neuropathy, again, that's a very interesting one. How much you understand about bruising? Yeah, again, I'm going to show you a video about how to distinguish between the two. Venous congestion, yeah, we'll go through that. Vascular compromise, yeah, I'm going to go through a very systematic approach. And again, I will go through blindness and understanding. So yeah, pretty much everything is on there. So we'll get through this, and it'd be interesting how we might even put the poll up at the end to see whether we see a shift in those numbers. So I always, I don't like the word safe. It's pretty much a pet hate when I'm teaching aesthetics, and we should never use it because it implies no risk, and no risk means gung-ho. And we need to understand now there is literature based around the use of cannula. And this paper was based around a 25 gauge cannula in the superficial temporal artery, and you can see how we can access it. But moving the literature on just a little bit further in terms of the most catastrophic conditions we can have, Katie Belasny's update. So from the first one in 2015, this was updated. And one of the remarkable things from this work was this: 6 cases of reported blindness were with a cannula. And again, the range 23 to 27, but the evidence doesn't stop at that point. A recent paper earlier on in the year was looking at 28 severe vascular problems with aesthetic medicine with hyaluronic acid. And what they found was 89, almost 90% of the severity, the severe cases were caused by cannula. And what this publication suggests is that we overestimate the safety aspect of it. So we shouldn't use the word safe. We should be using the word risk, because every time that you go through the skin envelope, there's a risk. Cannulas are lower risk, but there is still a risk. So try to get the word safety out your vocabulary. Always stay vigilant. And again, look at the areas of risk relative to blindness. So the very high is the glabella, nose, and forehead. Now, I'm going to be speaking later on this evening with Dr. Subio from the US, and we're going to look at nasolabial folds. And look where nasolabial folds sit in this risk group. They're in a high risk group. But the first things that we learn as injectors to inject. And why? Because we didn't fully understand how dangerous they are. So we have now not areas of safety, we have areas of risk, and you're going to have to try to mitigate the risks. And how you mitigate these risks, in my opinion, is understanding anatomy, and not just any old anatomy, which you see depicted in a book. I'm talking 3D distribution and depth. And you will hear from time to time people say, oh, there's no blood vessels in this part of the face. I can assure you that there is. And what you need to control as an injector is this, just at 1.4 of your bevel, because that's where all of that damage is done. That determines where the filler's going to go, where it's going to spread, and what type of problem you're going to have. And what you need to really think about is, where are these dangers? Where are the superficial and where are the deep dangers? And it's incredibly important that you have almost a roadmap, an aesthetic GPS within your head to start to think about where the tip of your needle is relative to where the likelihood that those vessels are likely to be. And what we want to do is we want to have this 3D approach, not a 2D approach as you can see here, but this classical 3D depth and distribution. Because as you see throughout this presentation, the distribution is not going to help you too much. Because what we need to understand is where the locations of these arteries are. And this is from Yanni von Logam's really nice publication. And what we can see here is the artery or the target area, the expected anatomical layer. And again, it's really important that we understand facial layers in aesthetic medicine, and the expected direction. So we've now got a pattern, we've now got literature available to us to say whether we should inject superficial and deep. And it really is as basic as this. If you know that the vessel is in a deep plane, layer 5 or 4, you inject in layer 1, 2, or 3. If you know that it's superficial or in the mid plane, you inject deep. And it really is simple. And what I've tried to do here is try to go through each zone and to give you the best opportunity to understand where each vessel is. So I'm starting here, and within the poll, a lot of people were frightened of this area, okay? And I get the reason why. It's because of the facial artery. The facial artery is incredibly variable, and I mean incredibly variable. There's 20% of us within the group today who will have a duplex facial artery and facial vein in the mid-face. So it's not always going to be in that position. It's tortuous. It moves in and out of the tissue. It starts very predictably below the mimetic muscles, below the commissure, and then above the commissure, it becomes superficial. What we also know, and what we're also understanding now, is that the diameter and the size of the artery gets smaller as it moves from the anterior border of the masseter towards the alar base here, where it's most superficial, and this is where it's at its most smallest. Okay, so go into the deep piriform space, your target is small. What you also have is the facial artery within that position. Here is 21 different variations, and there's 40 different variations and counting. So, like I said, distribution is not going to help you. It's the depth. So what is the depth in a deep piriform space? We know that it's at its most superficial, and we know it's at its smallest. So our injection here is deep, down onto the periosteum. There are there's been identified very small periosteal, which you probably wouldn't even be able to cannulate with your needle deep. So the plane for injection in that deep piriform fossa, where the facial artery is at its most superficial and smallest, is deep. And we use something classically like ultra deep to bring that piriform fossa forward, because we're trying to do two things. One is we're trying to lift 5 tissue layers, and we're also trying to replace a resorbed mandible and piriform aperture here. So that's the reason why we use the high cross-linked, high G prime, ultra deep, deep in the piriform space. So this area shouldn't frighten you. You should always be informed. And the other thing with this, the shortest way from A to B is a straight line. It's not angled like this towards the other commissure or like this, because that's a surefire way of going in through the back of the nose. And in the UK, we've seen a couple of sphenopalatine necrosis of the palate, the gum, and the nasal septum. It's a 90-degree, straight down, touch bone, and fire, deep injection. So again, 90 degrees, deep, ultra deep, slow, considered injection.
I wanted to thank you for that, Lee, because there's been many talks about how that needle goes in. Yes, we're trying to do a deep injection down onto bone, but there's been some discussions that we'll try and aim your needle upwards or inwards towards the nostril. So what you're truly saying is straight down, 90 degrees, touch periosteum, and slow injection.
Absolutely, 100%.
Thank you.
So again, chin and jaw. You look at Instagram, social media, it's all over it. Texan jaws, chins. Patients weren't bothered about profile until you start to see these images on the media. And one of the remarkable things that I used to hear around the circuit was the chin was quite a safe place to inject. And I'd always be very wary about safety, because you can never say never or never say always. And what we're finding now throughout the literature is, we're starting to see cases of necrosis with chin, because it's becoming so popular. And what we can see here is the submental artery. And the submental artery is the largest branch of the facial artery, which comes off of the neck. It comes over the submandibular gland and then enters the chin lateral to the midline. And what we can see here is the vasculature. And we just always tend to consider the mental artery here, which is the branch of the maxillary artery, which is pretty high up at this position. What we think about here is there's pretty much redundant for vessels. Well, now we know about the ascending mental artery and its anastomosis. And we make things very easy. We understand where it is and what tissue depth it is, and then we can use our technique as we wish. So when we're injecting into the chin, a midline injection deep onto the periosteum is a low risk. Anything slightly lateral to the midline, then the artery in a third of cases is going to be in the subcutaneous or layer 2. And the rest of the time, or the high percentage majority of the time, it's going to be intramuscular. So again, anything lateral here, you think cannula, or even deep down onto the pregial sulcus. Never with a needle underneath the skin lateral to the midline, because this is where you're going to experience those problems. The jaw is different. Now, the jaw I always place into two halves. I talk about the angle of the mandible and then the mandibular body here. So look, these are the layers of the mandible. And what you have here is you have several layers. And the key layer here is the parotid mesenteric fascia. So that tight fascial layer over the parotid gland. We need to be injecting above this, because if we're below the fascia, then we're going to be in the parotid gland. And in the parotid gland, you're going to have a world of problems, infection. You can also get malar edema, believe it or not, from injection into the parotid gland, because the lymphatics, the deep lymphatics from the eye, drain into the parotid gland here. You fill up the parotid gland and you have a backflow of a malar edema here. How do you know that you're above the fascia? Well, you can lift up your cannula and you can see the whole silhouette of your cannula. You're above the fascia. If you're below the fascia, then you cannot lift your cannula up. So it's a very, very easy way to do it. So if you try to augment the border here, cannula, very, very superficial. If you go into the gonial angle, it has to touch the bone. Okay, so never dangle a needle halfway in or halfway out of those angle of the mandible. So this is where we're going to put ultra deep on the gonial angle, and then RHA4 in that superficial plane. RHA4, I want you to call it or think about it as a superficial volumizer, or what I always term it as the undetectable injectable. It gives you super lift, and it's so malleable, it's incredible.
Lee, can I go back to the chin to ask you a question?
Sure.
So we talked about, the chin going deep down to bone, going a little bit laterally on each side puts us in a bit of a danger zone. So for women, we often augment just centrally at one point, but I think for a man that becomes a little bit more difficult, because we tend to try and broaden that chin. And that's where we're getting into a little bit of a danger zone. Can you talk about your technique and how to approach a male chin with both ultra deep or RHA4?
Okay, so I'm not too concerned on a man here because we know that the vessels are subcutaneous and intramuscular. So if I give periosteal injections here, then I'm going to be fine. That's close onto the chin, onto the lower border here. Higher up, then I've got the mental artery, which I need to consider. So lower down here, I'm fine. Now the male chin is between the commissure. The female is between the alar. So again, you can use 3 points. I tend to use 3 points across here.
Okay.
That only takes me so far, Bob. That only lifts from the bone to the deep fat. I don't get a big surface volume transition. I then use RHA4 over the top because the superficial fat at the chin is responsible for the contour of the chin. We know the male chin should sit anterior to the lower lip. So we use a cannula RHA4. Why RHA4? It gives us a super lift, but it also respects the facial dynamics because we know that the mentalis, it's an elevator in the lower face, highly dynamic area. Highly dynamic areas require highly dynamic fillers, or your patient's going to be locked in. Okay, so again, that's my rationale for chin on men. Commissure, 3 ultra deep, and then RHA4 with cannula over the top.
So that similar sandwich technique in the chin that we do in the jawline is advised.
Exactly, yeah. So this classical multi-layering technique, because we know that we have both static and dynamic compartments. So jawline here, what we have is your classical Mendelssohn's 5 layers of going from deep to superficial bone, deep fat, smast or muscle layer, superficial fat and skin. And here we can see that all of the danger on the mandibular body here is below layer 3. So to volumize, we use RHA4 in the superficial plane. Yes, we are using a volumizer in the superficial plane because this is what it's designed for. It's designed to give you maximum lift and for it to be completely malleable. So again, you're not going to see that rigid straight line when your patient yawns or smiles. Again, it's going to move with the tissue. So looking at that multi-layering, and I think you stole my thunder a little bit, Barb, but I'll let you away with this one because we're going to look at a video on how we're going to do this with that multi-layering technique. And this is ultra deep, like you said, deep onto the periosteum here. You can see the translation of its rheological powers to the surface. And then that only takes you so far because in my experience, I wouldn't use any static filler in those superficial compartments because it looks quite blocky, quite square, and you try to shape it. So this is where RHA4 really kicks in and it comes into its own world really in that dynamic sort of contouring. And again, so you have the classical static for static, so your highly crossing, highly cohesive, ultra deep, and then your RHA4, which is your dynamic volumizer. So you have your static and then you have your movement of your superficial fat and muscle over the chin. So again, it makes a lot of sense when we look at the chin. Here's our favorite, Bob, the temporal fossa. So we're going to look at the temporal fossa because we were a bit split on this. I think we were a 50-50. So firstly, we've got to say what's inside the temporal fossa and do we need to be concerned about it? Well, there are some very important vessels in there and some very understated vessels here. And again, there's a couple of important veins in this position. So these are the arteries. And again, people just classically think of the superficial temporal artery. What we've got to look at is a little bit deeper. And these are the deep temporal arteries, the branches, the muscular branches of the maxillary artery. And they will ascend from the infratemporal fossa upwards in a deep plane to feed the temporalis muscle. You have a posterior and an anterior deep temporal artery. And they're around about 2 centimeters behind the orbital rim, just into the temporal fossa here. And the anterior deep temporal artery is the artery which you're going to be concerned with the gunshot technique. This is the artery which you're trying to avoid. And again, understanding where the filler is going to be positioned is incredibly important. This for me was one of my biggest findings when I was looking at some of the vessels And the zygomatical orbital artery, which is a branch of the superficial temporal artery, is the largest artery in the temple, but nobody talks about it because it doesn't really matter. Well, there's been cases of blindness from the zygomatical orbital artery. So again, this will sit just above and it feeds the bicularis oculi muscle, and it can be in the subcutaneous plane here. So again, it's a consideration for the lateral orbit. Other things we need to consider is veins. And the reason why we're looking at some of the clinical implications from the middle temporal vein is that there's been fatalities, not just blindness or strokes. There's actually been fatalities from this. So remember, the veins in the face are mainly avalvular, so they don't have valves. So when you apply pressure through your syringe, it can go up towards the cavernous sinus or down into the pulmonary circulation. So again, one of these cases was a thromboembolic pulmonary embolism. And again, it was a fatality. So understanding the position of this vein is important, because I don't want you to do this. I don't want you to stick a needle in, because here you're risking two things. One, middle temporal vein, and two, you've got the zygomatical orbital, the largest artery in the temple. So we say no to needle in the lower temporal compartment. What we do have is a finger, and fingers are incredibly important. And if we just put our finger here, that's the position of the middle temporal vein. So you don't inject with a needle in that position. And again, this is why the gunshot technique was born. It was to avoid these lower structures here in the lower temporal compartment. But the other reason why the gunshot technique was formed was basically because the rheology of the filler wasn't right. So back in the day, we used to blend or hyperdilute filler, and we used to place it superficially with a cannula, and we used to get great results. Yeah, it was a bit of work moving it across, back and forwards, but it worked great. And then when something bright, shiny, and new turns up, we just tend to run to it and go, oh, it's amazing. We see people just give one injection down into here. And I just think, okay, so how's it going to get past the inferior temporal septum to fill the lower temporal compartment? Because it can't pass through the septum. So it filled me with a lot of questions, the deep injection, the deep gunshot injection. So one of the questions was for me is what is underneath? Is there any variability? And so I took myself off to a large hospital. I have a friend who's an interventional radiologist consultant. And I said, just do me a favor, just Doppler and ultrasound one up, one over here. To my surprise, I had a huge deep temporal artery, exactly where you'd stick your needle. And what we understand with this is that the layers of the temple, if we understand what's in there and where they are, we can begin to avoid. I'm a superficial injector with a 22 or 25 gauge cannula. And the reason why I do that is for two reasons. One, it's a safety thing. And two, we now have the rheology correct to place superficial. I use RHA2 or even RHA1 on some patients. And what we found from the literature with this is that we have 100% surface volume coefficient. So in the subcutaneous plane, you have the biggest lift or the biggest bang for your buck. If you place deep down, you're going to use ultra deep or RHA4. And what you have there, you have 9 layers to push before you even see a change. So you're going to have to use more filler, high G prime, highly cohesive filler. I'm using a soft light filler, which I can spread through there. The important thing is this. We now know fact that it's not a periosteal injection with the gunshot. It's an intramuscular injection. And inside that muscle lives the deep temporal arteries. So again, it's a consideration for you. And again, you need to justify your technique based around what you know. So I am all about the subcutaneous. And how do I know I'm in the subcutaneous plane? I can see the whole silhouette and shape of my cannula. If I'm underneath the superficial temporal fascia, I'm going to find it very difficult, big resistance to lift up. So those are the layers. You choose your product and you choose the area which is most comfortable for you.
Going back to the temple, I was going back to the temple. I was recently watching a cadaver lab performed by Dr. Codafona, and he was talking about the temple and its anatomy. And one thing he mentioned that I thought was interesting was that he said his if he was to inject a selected plane, it'd be that intrafascial space. But based on what you're showing us on that box there, we're really seeing a lot of veins and
Traffic.
arteries and nerves.
Yeah.
So it seems like that area could be quite concerning for us. So when we want to go into the subcutaneous fat, an access point that I typically use is just the inferior temple kind of lateral zygoma. And you don't want to see the graveyard needle, but you can kind of take not the needle, the cannula, and you want to kind of like windshield wipe it back and forth, and you can move it easily in this plane. Is that correct?
Absolutely. I think the great thing from that position, Barb, is that you can do the lateral eyebrow, which is very undertreated in female patients. And again, you can turn your cannula around to do the palpebral malar groove, and you can even access the SOOF from that position. So it's a very, very efficient position. It's a low risk entry point. And again, it's if you look at the intrafascial layers between the superficial temporal fascia and the deep temporal fascia, you've got things like the zygomatic temporal nerve, facial nerve, middle temporal arteries. Again, it's not a void. It's not void. And how do you know what tissue plane you're in? You can pretty much guarantee your subcutaneous when, as you said, you can see the whole silhouette, the whole shape of your cannula when you can bring it up. So that's my approach.
Now, when you go into that lateral brow, because I think brow lifts are becoming quite popular with filler. And if you're using your cannula, the skin gets much thinner here, but you're still going to be gliding very smoothly, and you just do like little micro kind of aliquots in a retrograde fashion for that brow lift.
Yeah, just do little mini linear threads, really, ensuring that I'm above the supraorbital rim, because I don't want to place the filler above my eyebrow. It's going to push it down. I want to place it underneath to lift. If I want to project the eyebrow, then I'm going to just place it directly behind the eyebrow. So I lift up the eyebrow first and then place my filler just above the supraorbital ridge. And then,
now
again,
sorry, I will go back to this area because it's really popular again. Now placing and using a needle down to periosteum and doing tiny little boluses along the bone. What's your thoughts on that versus using a cannula to lift the brow?
Yeah, for me, I just use a cannula, because the reason why I use a cannula, I've already got a cannula in the temple when I'm doing the lateral brow anyway. So, and I find that the lateral brow from this position, it just gives me a really nice shape. A needle's fine in that position, but again, needle is multipuncture, and anything multipuncture means multiple chance. So again, it's about mitigating any risks and just trying to reduce the amount. When I'm talking about risk, I'm not always talking about blindness or vascular. I'm talking about hematoma, which can be pretty distressing on a female patient.
Yeah.
If they've got a large hematoma, they tend to hang around for around about 15 days.
That's very true. I just had a treatment, the Morpheus 8, and it's microneedling, and I had a huge hematoma, and I had a black eye for about 2 weeks after it.
Yeah, it's not a nice thing to go through. Okay, so we'll move to the forehead and the glabella, and again, we're now into that real territory of internal carotid artery and the cutaneous branches of the ophthalmic artery. And we know that within the crease or slightly lateral to it now, we have the supratrochlear artery. Again, so you got a flip of a coin here on where it's going to be. So like I said at the very beginning, the get-go, distribution will help you a little bit, but it's not going to help you overall. Supraorbital artery, again, is a cutaneous branch of the ophthalmic artery, but the location of this is not in the midline. It's just at the medial limbus of the iris. And again, you have to start thinking about, what's the depth, because it's very common to have two supraorbital foramen. So you'll have two supraorbital arteries. You'll also have a deep artery and vein which runs quite close to the temporal fusion line here, which will supply part of the scalp. So it comes down to this depth. Depth is critical for the forehead here. And you can see, this is an actress from Glee, I can't remember her name, but you can see in the first 15 to 25 millimeters, you can't really see the vessels, and then they appear above that inferior frontal septum, and then become really, really superficial. So going back to our understanding depths and products here, then my my method of reinflation of the forehead is deep injection in that pretty avascular plane, deep layer 4 here, because we know that all of the vessels in this position are going to be superficial. Again, if you're going in the glabella, this is a little bit different, okay, because we now have a lot more understanding of the glabella. And the glabella now you can have both deep and superficial. So that leaves us in one position. What do? We're damned if we do, damned if we don't. And again, this is the great thing about an adaptable and versatile portfolio of fillers. We can use RHA1 intradermal. And I'm talking about what we call flat blanching or superficial dermal stretching. We can lift up that, again, typically after using neuromodulators in that area, 2 weeks later, you reach for the RHA1, and it's a perfect marriage here. No tyndall, no palpability, no lumps and bumps. And again, we can never say never and never say always in the glabella, because we always thought everything was deep so we could go superficial. Now we know that there's superficial branches of the supratrochlear artery. So it's an intradermal injection into the glabella. And I would suggest strongly that you do that after neuromodulators, because it's going to make that crease a lot shallower for you. We're going to move to the tear trough. And again, I don't need to say this, but there's one product licensed for the tear trough, and this is Redensity 2, low hydrophilic, low hygroscopy, spreadable, no tyndall, ideal marriage for this area. What you're likely to see here, you're likely to see that classical malar edema, or the edema which typically appears around about, I would say, 5 to 7 days post-treatment. So your tear trough looks great, your patient calls you up and says, I've got a lump under my eye, why is this? It's normally to do with depth or amount, or the patient propensity to swell. So again, this is a very unforgiving area. And we need to understand the relevance of understanding the depth of these facial planes, because we want to be injecting in this little blue area here underneath the muscle, which is the prezygomatic space. Why? Because 90% of the vessels are above the muscle. So again, it gives you a better chance of having a lower risk injection. So what is this anatomical basis of malar edema? Well, you see classical edema between those two structures, the fixed structures, the bicularis, retaining ligament, and the zygomaticus cutaneous ligament, and it's down to the SOOF. The SOOF is a defat static compartment, and it's adhered to the bone. And what we have here is we have between the SOOF, we have running a structure called the malar septum. And this malar septum will split the SOOF into a superior and inferior part. And this barrier is impermeable. So if we place our filler on top of the malar septum, we compromise the lymphatics. And these lymphatics are predominantly in the skin, very, very superficial. And they are so delicate, it can take almost 12 months to have a resolution in this area. And like I said about the malar edema down here from the parotid gland, again, the mandibular gland is responsible for the drainage from the medial part of the eye. So this is what you're likely to see. You're likely to see your patients come in with a speed bump under their eye. And again, this was a case referred to me. This is hyaluronidase. Again, I understand in Canada that you have compounded, so the pharmacy make yours. So it could be super strong or it could be super weak. You don't know, which is really important. We mix our own. We have 1,500 units, so we can control the concentration with this. So what do? We use, in the UK, we use 1,500 hyaluronidase in 1 cc. And again, typically for the tear troughs, you don't want to go back into this area. So we use 150 per tear trough. Again, you don't know whether or not what filler it is when it's being referred to you, or whether there's been a high amount of HA with high cross-linking. So the reason for 150 units is you have one shot. Okay, you don't want to bring your patient back time after time. You firmly massage that area. Sorry, Bob.
So Leah, sorry to interrupt, but I have a question about some edema in the tear trough. So sometimes, well, this isn't an occurrence that happens often, but there have been times where a patient does have a history of tear trough filler, and then we go ahead and treat their orbicularis oculi with toxin. And you don't see it at first that they might have some lymphatic compromise from the placement of filler. And then all of a sudden, that relaxation of the orbicularis oculi 2 weeks later will present with some edema. Now, do you see this happening often? And if you have seen it, is there a way of knowing which patient this might happen to? Like some people, their tear troughs, you come in and they look fine, you know, they're full, but they look fine. And all of a sudden you're like, whoa, look at that edema post toxin in the area.
Mm. So I'll ask them, do they suffer from puffy eyes in the morning, after a night out on the wine, or after a salty meal? Do they suffer with bags under their eyes or puffiness? If they say yes, then I don't think they're a great candidate for it. The other thing about neuromodulator at lateral orbit here is, in my opinion, people use too much. I use tiny amounts and get great results. So again, it's what I call minimum inhibitory dose. I use the smallest amount to get the maximum effect in here. Remember, you've got a huge, almost like an aviator type of sunglass shaped muscle, and you're treating around about 5 to 10% of this muscle, and people are using the same dose as a glabella or a forehead, and I really can't understand the reasons why. This muscle will help with lymphatic drainage by using it as a pump. You stop that, then you're going to get inevitable lymphatic compromise. So again, you have to be incredibly wary, but ask those questions before and ask what product they've had. So if I've had a volumizing filler into here, then you can bet your bottom dollar that they're going to get an edema.
Perfect. So just to summarize, find out the filler, find out if the filler is causing them issues ever, and if so, probably don't treat or treat very lightly.
Yeah.
Thank you.
Okay, so again, warn the patient that they're going to be flat. They may have a hematoma when you're doing this. Review if the swelling is still there after review, or corticosteroids, prednisolone, around about 30 milligrams for 5 to 7 days. If it doesn't go after that, then it's hand holding and reassurance for maybe up to a year because you've damaged the lymphatics. Mid-face, we're going to look at how, again, the same principle as me and Barb were talking about with the multi-layering, because we have both static and dynamic compartments. These deep compartments here, these are the lateral medial soothe, deep lateral, deep medial cheek fat separating the facial vein. These are static onto the bone, and these are our superficial, highly mobile compartments. And what we found is that we can target these with our ultra deep, and we can target the areas which atrophy here with our RHA4. So again, you have the classical static and dynamic. So what is the mid-face? Well, the mid-face, if we split it into 3 sections here, and the blue line is the mid-cheek groove. Anterior to the mid-cheek groove, so in that zone A, we have the facial artery, facial vein, and the angular artery. In B, we're likely to encounter the infraorbital and zygomaticofacial artery, and the yellow line is the inferior border of the zygoma. And in that area here, we're likely to encounter the transverse facial. Like I said a little bit earlier, you can't rely on the facial artery, because here you can see type 4 has a massive transverse facial artery. Again, you will experience these patients who will not have a facial artery. Also, you're looking at things like duplex angular arteries. And again, this is Cotofano's work here to show you that lower down, almost a third of people have a duplex artery in this position. So again, you have to be incredibly wary about this area. Again, the distribution element you have to focus on, but it's all about the depth. And it's the same when you start to see surface topography. So the mid-cheek groove. What is the mid-cheek groove? What is it? Well, the mid-cheek groove is an area which you never want to inject into. You want to avoid any deep crease or line, because that's where major vessels are hiding. So here in the mid-face, we have 2 folds, the nasolabial, where the facial artery would likely to be, and the mid-cheek groove with the structure called the facial vein running through. Remember, the valve We don't have valves in the facial veins, so it can go up or it can go down if you squeeze hard enough. And again, this vein is incredibly important because it's close to the infraorbital. It's close to some other anatomical structures. The green line here, which I've drawn, is the zygomaticocutaneous ligament, and the facial vein will run and hit this ligament and then start to course underneath the tear trough, around about 2 millimeters under your tear trough, and then continue as the angular vein. So again, just identifying some little landmarks can help you. We have lots of landmarks available to us, especially in the midface. We have a wealth now of publications to tell us where it is. So making it very easy for you, we have 10 millimeters from the infraorbital rim and 26 from the lateral is likely to be the position of your infraorbital foramen. But again, you'll hear me say this 1,000 times. Distribution is going to be incredibly variable. And it's the depth of the distribution which is really the key to those lower risk injections. The infraorbital not just supplies the skin of the cheek. If you're concerned that you may have a vascular compromise from this, you're going to have to look intraoral. So you lift up the patient's lip and look at the gum and the mucosa, because again, when we look at the infraorbital artery, we can see that it has three distinct branches. We have a zygomatical branch, which runs out towards the zygoma. We have a vestibular branch, which goes to the lip. And then we have a nasal branch, which goes to the nose. And here I've made this very simple. You don't have to read this wonderful article. You just need to draw a line at the medial limbus of the pupil, and you don't inject deep lateral to that line. You don't inject superficial around it. So again, it gives you an idea. And again, you would use RHA4 in the superficial plane and ultra deep, or RHA4 in that deep plane. Staying on that theme of the midface and its incredible variability, we have the transverse facial artery. Again, you'll have two branches. One of the branches will come up here called the superior emerging branch to supply the skin of the cheek here. And then you'll have a deep branch which will supply the parotid gland, the parotid duct, the facial nerve, and parts of the masseter muscle. So you have two branches of the transverse facial, one going superficial and the other deep. And it will perfuse quite a lot of the cheek in some of our patients. In some of us who don't have a facial artery, it will pretty much be the main irrigator of the face. So where is this? So you have your little finger, and you had your finger here for the middle temporal vein. You just move it to the lower border here, and that's your transverse facial artery. If you want to be really, really pedantic and you like numbers, you're very metric, then it's 17 millimeters below the border in the subcutaneous plane. So again, you can use anything here, RHA2, RHA3, RHA4, depending on the skin quality in the submalar hollow. Never a needle, always a cannula. Lateral cheek, and I know we had a little bit of feedback from this. What we have is you either have no foramina, 1, 2, 3, or even 4. And why is this important? Because you have a very significant vessel at this part, and we've seen 2 cases of blindness in the UK from lateral injection of the zygoma. And the zygomaticofacial artery is a branch of the lacrimal artery which runs on the floor of the orbit, supplies the lateral rectus muscle. The zygomaticofacial pops out of this foramen and supplies the skin of the cheek. And so there is your direct connection between the cheek and the ophthalmic artery. And the literature tells us around about the position, and again, this can be incredibly variable on our patients, but around about 25 millimeters from the orbit here, you can see that there is a likelihood of a foramen. So what does this mean in terms of topography? If you can identify the inferior border and the zygomaticus cutaneous ligament, it's quite obvious. On some people, it extends down as the mid-cheek groove, and then it starts to curl away. You can start to see that this runs through the lateral souph, just like your CK1 and your CK2 tend to run through this area here. So you have to be very, very careful. Lips. Again, I think we had 70% of people who were inject superficial. Again, is there a common lip pattern? I would say no, because it's incredibly variable. It's tortuous. It's not straight lines. This is average depictions you would see in a textbook. It can be large And when I say large, I mean bigger than your superficial temporal artery to perfuse quite a very active dynamic area. It can be unilateral, so you can have one large artery going all the way across. Normally you have bilateral arteries, and the size can differ. This is what you're likely to see in what we call real life, is a very tortuous, highly anastomotic superior labial artery. And where is this? Well, again, it's understanding depth and it's understanding position. And what we know from the presentation is that the facial artery is below the mimetic muscles and then starts to rise superficially. And here you can see the very tortuous path of the facial artery. As it reaches the commissure, it comes superficial. Look how superficial it is here, those deep piriform Skurdi-Katz. Very, very superficial here, and it's small. So again, you're going to have to take just these little nuances into consideration. Here we have the superior labial artery, and it branches off. And it branches off in the lateral third, lateral to the alar. And how many times have you seen a bruise or a hematoma in this position, lateral? Everybody's seen one, because people will go through the artery at this position. The artery is likely to be in one of three positions. So I like to call these wet, muscle, and dry. So the submucosal is the wet or the non-keratinized side. The muscle or intramuscular is the orbicularis oris, and the subcutaneous is the dry part. So the keratinized, where you put your lipstick. What we know from the literature, from the biggest study which has ever been conducted, is that the subcutaneous plane has a 2% risk. So it's not safe. It's just low risk. So again, you're going to encounter the artery in these different tissue planes. And again, if we make a cross section, and I'll do a plug here, Barb, this is from a book which I've just written, again with some incredible images. It shows you the cross section of the lip, and that the position of the artery in 80% of your cases is likely to be behind the muscle in that submucosal position. To further corroborate what we're talking about, Kotafana's work was done and followed up by a large Korean study which showed exactly the same thing, is that the majority of cases, the artery is going to be in the submucosal position. Well, we don't stop there, do we, Bob? We keep evolving and we keep moving science forward, because the publications keep landing on our doorstep. And we're starting to see the frequency now of the superior labial artery in the subcutaneous plane. So again, Bob seen me inject lips multiple times, and I inject in position 2. And there's a reason for that. Again, I've got a publication coming out in January with this in, and I like to inject there. But as we go through the tissue planes, we start to see the numbers begin to change. So intramuscular here, classical hematoma in the lateral part is the intramuscular plane. So again, you have to be incredibly wary when you're in this lateral part, because it's pretty easy to find the artery. And then the submucosal. Then laterally out here, you can, if you stay very superficial, you're okay. If you go under the skin, then you're likely to hit the vessel. But look at the midline. Look at the midline in submucosal injections. I'm not a huge fan of submucosal injections. And when we run the size of the diameter, again here, this is where you're likely to find the artery in the lateral position rather than the midline. What we want is we want safe and predictable injections. So for those people who inject deep, you have a lot of work to do before your filler can be seen. What I do is I place superficially, subcutaneous, and my filler has a little bit of work to do. Not because I'm lazy, it's because I can use softer filler and I can use less filler to get the same result. And what this looks like is you've got a sagittal split of the lip, you place it behind the muscle, it has to push everything forward before it gets a result. Also, if you place it submucosally, look at the shape of the muscle. The muscle is curved towards the front of the lip. So this is where you get those hanging baskets which come down from the submucosal position, because you're behind the muscle. The muscle is going to redistribute the filler into that submucosal. And you've also got an 80% chance of hitting the artery. So we have a 1.7% chance. We have lots of filler that we can just push forward very easily. And it gives us that common sense approach. And you can apply the same principle to the lower lip. Here we can see the classical 5 layers, large inferior labial artery. Again, look at the size of the subcutaneous fat here. Look at your target. So your target is here, the large area is subcutaneous fat away from the artery in front of the muscle. And again, just the consolidation, look at this lateral position where the artery is superficial. This is where the hematoma pops up all of the time. For those of you like tenting, well, 60% of the time, you're landing your filler pretty much on the artery. So it's only going to be a matter of time for these multi-puncture, multi-serial injections before you have a problem. I don't do these.
Can we go back to the lips? Because as nurses, I think we do a lot of lips, and they're becoming more and more popular. Now, when I saw you speak in Monaco, you talked about the labial artery and how it varies in depth as it goes throughout the lip. And but typically, I believe it was around the depth of 6 millimeters at most superficial. And back then, you were talking about using the 4 millimeter needle technique. Is that something you're still using? And if not, what is your advice on staying superficial?
Yes, I still use the 4 millimeter needle. Again, I use it vertically in the subcutaneous plane because I've got less than 2% chance, and I've got in zone 2, which you see the frequency of the superior labial artery is it's pretty absent. Never say never, though. Never say always. My advice would be to ensure you're superficial and ensure you're using the right product, because I think what most injectors do, Bob, is that they're scared to have tyndall or lumps and bumps and palpability. That just tells me that the rheological selection is incorrect. So RHA is completely moldable, malleable. It's designed to move and flex with the lip, has incredible biomechanical endurance. And again, you don't have the issues with palpability. You don't have the issues with lumps and bumps. You don't need to hide this. We spoke through the presentation about superficial volumizing. So I would say you should see the shape of your needle if you're using a classical 13 millimeter needle or a cannula, but not the gray. Okay, so you can lift up. The other tip I always say to people is inject the lips with the patient's mouth closed. That means that you're injecting the subcutaneous, the dry part. It's when people start opening the mouth and going in or going like this, that you're just pointing towards the danger. Point away. Yeah, point towards the subcutaneous plane. So just little simple trips like that.
Okay, just a few more follow-up questions. So when you're doing your superficial placement of product in the lips, are you most often using RHA2 or even something thinner like RHA1?
Again, it depends on the age of the patient and what I'm trying to achieve. So younger patients, RHA3, so volumizing. Older patients, RHA2 or rejuvenation or refresh patients. And again, that complete restoration, I'll use a combination of RHA1 and RHA2 for the older patients.
Okay. And then finally, one more question about the lower lip, because although I think it's quite easy to evert an upper lip, sometimes that outwards eversion of a lower lip becomes a little bit troublesome, and you'll get just like a forward projection of the lip. But knowing that we have to treat more so the wet dry border in a deeper plane to try and invert it, that's kind of what I've been taught as a technique. So do you have some advice on how to create that eversion of the lower lip so you get that pout, but doing it safely?
Yeah, so it's a myth that placing filler in behind the muscle creates an eversion. It's absolute nonsense. Okay. It has to push all of those tissue layers forward, and I'll dispute that with anybody because I've done enough lips over almost 20 years to know which avert are lips, and that's placing a superficial plane. Okay. More importantly, the vermilion border, that little discrete tube you inject into, if you do that, it does that classic, I'm trying to get my hands right, it gives you this in the upper lip and this in the lower lip. It gives you that classical when you put two Pringles together, it averts both of them. So it's when you get that vermilion border right and it runs through the tube, it will avert, and then you place it in the subcutaneous plane, it just flops the lip forward, okay? Because if you think about it, you're going to have to push it through the muscle to get it to avert the lip. It makes no sense. So placing it superficial, subcutaneous plane, averts the lip. Vermilion border projects and averts at the same time.
Okay, so the best access point for the lower lip to get that eversion and to get into that tube, would you say is, what is the depth and kind of the access point for that?
Okay, subcutaneous, two little bilateral lobes, because embryologically we fuse from the Meckel's cartilage here. and we have an embryological lobe here. I inject from above, directly in, away from the artery. And then the vermilion border, I use the lateral alar of the nose and then just flow it across, just one injection.
Okay, perfect. Those are great tips. Thank you.
Thank you. So filter columns, right, we've got a lot of ground to cover in some short time, so we'll try to fly through. Filter columns, I don't do them. Why? Because not all patients have them and nobody ever requests them. From an anatomical standpoint, this is your distribution. So this is Yelda Pinon's work on whether you can have a single straight, double straight, or a forked. Again, you're going to say to yourself, that's not going to help me. I am going to help you because the columellar arteries in the filter column run in the superficial and deep plane. So basically, folks, you don't have a safe plane to inject in the columellar area or the filter column area because they are above and below the muscle. So again, you're going to have to take your chances. So looking at some of the lower lip and upper lip topography for the lower risk, then our lower risk is in front or superior to this green line, never behind. The same with the lower lip. Find the wet-dry border and you inject anterior or in front of that. Again, from a little publication that I did, you want to inject superficial here into the lip and intradermal if you're doing the filter columns. Bob did ask me what I use. Well, I use some very fancy spectrophotometry. And again, it shows me with an overlay, RHA2, restorative refresh. Look at the aversion and the projection. So again, it's how you and what you place in what tissue plane. And that's just 0.8. Let's give everyone some nightmares. Okay, and the first nightmare we're going to show you is a map of the US. Okay, and specifically here, the Mississippi watershed. And the reason why I'm putting this on is, why do we see such unique patterns of necrosis? Well, if we stop the supply of the drainage of the Mississippi, this area of the US will become arid and dry. And it's the same principle if we inject and block the inferior labial artery here, then we get this unique area of necrosis. And what we're beginning to understand now is that very unique parts of the face will have what we call choke anastomosis. And what this means is, it means the body or the face especially has the ability to shut down the system. So you know when the bank robber runs into the bank and all the shutters come down and the alarm goes off? It's like when there is filler in the artery, the body can shut it down and keep it there. Why? It doesn't want it to go to the eye or the brain. It's a very clever way to say, I'm going to sacrifice some skin on the tip of my nose because I don't want it to go to my eye or to my brain. And this is the phenomenon of choke anastomosis. And this is the importance of understanding areas of ischemia. How do we get this? Do we get it through compression or is it intravascular? Listen, folks, compression doesn't exist, okay? I know that for pretty much a fact. If you fell asleep on your supratrochlear artery for 4 hours, you wouldn't wake up with necrosis. We're not designed, we don't get compartment syndrome in the face. What we found from all of the literature is that we always find biopsies with intraluminal filler, always. And this is the problem. How do we diagnose it? Well, you have your classic pain and blanching, but some people don't see it because they don't ask the patient for feedback. They don't look at the skin or clean makeup. So what they may see is livido, the fact they have slow capillary refill time or skin breakdown. And what we have here is, well, I'll ask you whether this is a VO or a hematoma. What would you think, Bob?
Well, based on that libido pattern, I'm not liking that, but your cap refill is quicker than when I see the lip, but I still think it's an occlusion.
It's just a hematoma.
Oh.
So again, cap refill is one of your best friends. What do you think about this one?
Well, absolutely a vascular.
Yeah. Okay. So that's one thing, how to diagnose over a hematoma and a VO. Normally, a hematoma will pop up straight away. You know when you got a bruise. You go, oh my God, I've got a bruise. With a VO, you tend to have professional denial. You go, that's not blanching. That's not blanching. That doesn't look white. That looked white before. No. Right, so that's the difference. Cap refill time is a big player when it comes to understanding whether it's a VO or whether it's a hematoma.
So I want to go back to that video of the nose that you did. There
This
is,
is not my case, by the way.
um, but you know, like the cap refill's there, but it is a little sluggish, and that's often where I think bruises become a little bit confusing, because around a bruise sometimes you'll get that refill, but it still has that sluggish appearance to it. And the part that I found confusing about the nose is like the tip, and there's like, it looks like a little bit of a libido pattern going on at the tip and at
I can
the,
I can assure you that was a hematoma, because these
yeah,
are the things that get sent through to my phone pretty
yeah,
much on the hour, every hour. I'm really worried, is this a hematoma? So we always do cap refill tests.
yeah,
And again, we don't know whether the patient just had a vascular nose. So rosacea at the tip of the nose,
right,
we don't know. These are the questions I ask. You know, this is not just the only information we get from the injectors. We get a lot of information, pictures before and afters, videos from different angles, affected and unaffected sides on different parts of the
yeah,
face to give us a baseline. So lots of things will help us. What you're not going to see within your classical 5 stages here is you're not going to see all of these in a linear fashion. What you may see, you may miss the pain, you may miss the pallor, and you may see libido. Or 2 days later, classically, your patient comes back and they've got pustules on the lip. They think they've got an infection. So pallor is reduced blood flow to the area. So this is that classic blanching, which appears straight away. And how we understand this is we need to go back to basics, and we need to understand the real fundamentals of tissue perfusion. Pink tissue is the balance between arterial and venous blood flow, and it's the harmonious nature. And what you have within the skin is zones of what we call arterial dominance and zones of venous. So you have this equilibrium between venous and arterial. What happens when we blanch? We block those arterial cones, which you can see in yellow. So you have that classical blanching appearance. You have no blood supply to the area. And what that looks like on the skin is this, that classical blanched appearance. And we've already seen that within there. So that's the blanching. And again, this is a case which is sent to me from Albania. This is a transverse facial artery occlusion. And again, she was worried about hematoma. And I said, okay, do a cap refill time. And she did this, and yeah, transverse facial artery occlusion. So that was 30 seconds capillary refill time. So why do we get reticulated libido? Again, what we have is we now have a shift from the balance of equilibrium from arterial and venous to venous congestion, because we have no arterial cone. So now we have a big zone of venous congestion. Our third stage is pustules and a breakdown. We don't get sweat, we don't get sebum, the pH changes, we have an overgrowth of anaerobic bacteria because we've got no oxygen to the skin anymore. We're starting to get into wound therapy. Again, the coagulative stage, it may just look like a bruise. Again, this is through the congestion of all of those red blood cells, the endothelial injuries, and this is where you're starting to get that necrotic tissue, which will eventually turn into eschar. And this is wound management. You don't want to let it get this far. If it gets this far, I would say it's being mismanaged. You're going to have to refer it pretty quickly if you get to this stage. Okay. So again, quickly and swiftly, how do we do it? We use the magic bullet, hyaluronidase. Hyaluronidase, we have 1,500 units. We can make our own dilutions. I know that in some places in Canada, it's compounded. It breaks the beta-1,4-glycosidic bonds, and it's a soluble protein, and it's responsible for degradation, natural degradation of glycosaminoglycans within the tissue. You have 6 in your body, high R1 and 2 being the most common. It has a very short half-life. It has an immediate action, and it has a variable duration around up to 48 hours. People are worried about getting subdermal atrophy. I'll tell you now, hyaluronidase does not cause subdermal atrophy. Infection and ischemia cause subdermal atrophy. What we need to know is that there are some drugs which make it harder for the hyaluronidase to work. And again, you'll see things thrown at an occlusion like non-steroidals, steroids, aspirin, lots of things work against it. What we do know is that lidocaine has no effect on hyaluronidase, so you can mix with lidocaine because it's extremely painful. And if we use it without benzyl alcohol, so unpreserved saline, its activity is higher. Again, within the US and parts of North America, they will use different sources. And again, they've removed amphidase now because it has a preservative called thimerosal, which was the fifth most common allergen reported within the North American groups. So do we do a test or don't we do a test? And do we do it for long enough? And again, we look at the literature. And what we find from the literature is that you'll get a localized reaction. And I'm not talking anaphylaxis. We're just talking mild erythema, small angioedema. But if you look at this breakdown, what you're seeing is that 66% of the cases, you're going to have to do an intradermal test for longer than 1 hour. What does it look like? Well, again, you'll know what an urticarial rash is onto the skin. And again, we don't do intradermal tests for the emergency setting. It's a time critical event, and we're not going to wait over an hour to see whether we're watching the skin of the lip dye, whether we're trying to get a reaction which we can manage really easily with some antihistamines or some steroids. One of the interesting things we found is that the preserved saline, benzyl alcohol, was the bigger culprit over the hyaluronidase, so almost 3 times more likely. So again, we need to take that into consideration. The other things when we look at the studies is they were using different drugs, they were using different methods of administration, different doses, different volumizations. So probably even now the amount is a lot lower. What's the most efficient depth? Is it subcutaneous? Is it intra-arterial? Well, the evidence tells us that it's subcutaneous or even a periosteal injection with this. So you have to really think about what depth you've given it. Don't try and find the artery, just try and find the tissue above, because again, tissue permeability, this is what this drug's for. It's a dispersal drug. What dose do we use? It's dependent on the amount of filler, the cross-linking of the filler, the amount you've used. We know that biphasic products are easier to break down because of the bigger surface area, because of the non-cross-linked HA. One of the interesting things is that we see very small amounts used for correction, but that was 11 years ago. Now we know we use more filler, more areas, higher cross-linking, higher concentration of HA, so we need to increase the amount of hyaluronidase we're using. How do we use it? Well, the mighty Claudio Di Lorenzi come a few years ago now with his high-dose pulsed hyaluronidase, and it works phenomenally well. And I was always an advocate of this anyway. I just wasn't brave enough to write down or to put my head above the parapet and say we should be using more. Because what we know now is that once we inject the hyaluronidase into the tissue, we have dilution deactivation by anti-hyaluronidase enzymes, which we possess in our body. And for the very nature of this dispersal drug, it diffuses away from the tissues. So we are putting it in, it has a very short half-life, and it's not working. It's not concentrated enough or long enough on. So what I want you to think about is this. Your tissue is a bucket full of holes, and your hyaluronidase, you have to keep filling it up. Why? Because you have dilution, you have diffusion, and you have degradation. The other thing I want you to consider is this. The use of lidocaine without adrenaline. It acts as 2 things. Number 1, it acts as a vasodilator. That's great. Number 2 is the most important. Anyone who's tackled enough vascular compromises knows that necrotic tissue and hyaluronidase don't mix. It's incredibly painful enough to stop the patient having treatment. So given hyaluronidase, mixing it either with the hyaluronidase or injecting before, it's up to you, allows you to rigorously massage the tissue, because to get rid of a VO or an embolism, you need 2 things. 1 is biochemical with the hyaluronidase, and 2, it's biomechanical with your thumbs. So again, massage is one of the most critical factors. So how do we do it? We inform the patient. Then we get a baseline capillary refill time on the affected and unaffected sides. We mark out the area, the complete area of blanching or ischemia, because we know those choke anastomosis is holding the HA within that area. We clean the skin. I give lidocaine without adrenaline. We only put 1 cc into 1500 units. We have a very, very concentrated dose. We have a dispersal drug, which wants to escape everywhere. We want it to be as concentrated as we can. We inject the whole 1500 units in, and then we massage for 5 minutes with warm compress. And when I mean massage, I don't mean a Swedish massage when you go to the spa. I mean when you go to the sports masseur and they hurt you and it's like, you're pushing the skin onto the bone. You're trying to break that product into pieces to allow the hyaluronidase to work over a bigger surface area. You can give aspirin, and again, I know in the US they like to give antacids at the same time. That's cool. And then you repeat until your CRT is back to normal. Now, normally this takes two rounds, but you can do up to 4. The reason why I say 4 is that you're tired and the patient's tired, and then bring them back and then start the process again. Now, from Claudio Di Lorenzi's very interesting paper, then the disclaimer, he was using 1500 units in 10 mils. So again, it's a very diluted dose. And again, if we take this and we used it in the retrobulbar, if a patient went blind for retrobulbar, then we know that the retrobulbar space has only room for 5 cc's. So again, you could cause orbital compression by using a full 1500 units. The other consideration that we're looking at in the UK is tissue conditioning and reperfusion. So are we opening the blood vessels too fast to let all those inflammatory mediators which cause necrosis in too quickly? Should we be given smaller doses of hyaluronidase as we go through? Again, the jury's out. We're going to have to do more work. So to finish, pretty much, your high-dose pulse hyalase clinical assessment must be ongoing with the patient. You must be in contact all the time. High dose, make sure that there's enough hyaluronidase in the tissues for long enough because it undergoes diffusion, degradation, and dilution. And finally, please understand and, more importantly, respect anatomy, because it will always come back to bite you in the end. So I will stop sharing and we'll answer some questions. I know that I'm a little bit over time, but I'm happy to stay if people want me here.
Thank you for that presentation. It was so informative, and every time I hear you speak, I feel like I'm learning more and more and bettering myself as an injector, and I'm sure everyone who paid attention today and participated feels the exact same way. So one of the questions that came in, and you kind of went over it a little bit in a slide earlier on in the lips, but your thoughts on the Russian lip technique. You had mentioned when we're doing that technique, we're getting really close to that artery, so it is quite a risky approach to treating the lips. So I think we answered that question. Is there anything you want to add to the Russian lip technique and your thoughts on it?
Yeah, I'm always very wary of fads and false icons and gods. I've seen enough of them within my career come and go, and we've seen a multitude of techniques based around what you normally see on the Russian technique. It's young women with full lips with organized swelling, and that's what it is. You don't see Russian lip technique 6 weeks later. You see it pretty much instantaneous, and they look flat where they've squashed them onto the face or photoshopped them or whatever they've done. Any multi-serial or multi-puncture injection is increasing the risk. And again, what we know from biofilm, even things like nodules and biofilm production, if you go in with a needle and start to fan it round, you're just seeding the tissue with bacteria. So the less you can puncture the lip, then the less you've got risk of hematoma, edema, infection, VO, and blindness. So Russian technique, it may be good in some people's hands. Again, I'm not a multi-puncture type of person because I like to sleep at night, and I'd like to see an evidence base based around it rather than somebody's approach. Because Bob, really, what I think aesthetic medicine has been for too long is eminence-based. You see incredibly famous people injecting on stage, and there'd be no rationale. It'd just be their technique. It's the lowest form of evidence that we have. And until we start to get more of an evidence base, then we have to be super guarded when we come to using people's techniques. Always remember that the spike of complications is always after a conference.
Absolutely. I think we get some new ideas and we want to test them out, and that's where I don't know, we run into some issues. There's another question back on the lips, because again, they're very popular for us nurses. Do you like using the cannula on the lips? Is it something you often use?
Um, no, because one of the things I don't use is regional anesthesia in the lips, because two things. One, it creates a lip tonicity like this, and you can't get an appreciation. Lidocaine causes secondary edema, and it takes away the feedback from pain. And I find that I had to use that with a cannula because the cannula in my hands was more painful, really incredibly painful for patients. And I was always unsure of which tissue plane I was in. So that's the reason why I don't tend to use it. The only place I use it is in the cutaneous lip here for the barcode lines. So I'll break the retinacular fibers, and then I'll place RHA1 or RHA2 and then RHA1 with the flat blanching technique above. That's the only place I use a cannula, in the lip. I don't use it into the lips, but I know I've seen some people with some fabulous results. The other thing about a cannula is I don't think I can get a sharp vermilion border with
I
a
agree.
cannula.
I agree with that. Okay, so moving back through a few anatomical areas, because we're going back into the temple and talking about that superficial technique, venous congestion is something we can run into. Do you have a way of identifying? Yes, we see some patients who are quite vascular in this area, and you might run into some issues, but do you have any tips or techniques or product selections if someone is more vascular, just to help us avoid that outcome?
I think one of the things you can do if you've got vascularity that you're concerned about in the temple and it's superficial is to tip your patient's head forward and get them to engorge the vessels and then mark them out. That's a surefire way you can start to avoid. Most of those vessels are superficial. Um, Venous congestion, again, the jury's out on what is causing that. So it's either a blockage of the vein you've injected into. But one of the interesting things I was discussing just a little bit earlier about choke anastomosis and that hemodynamics between, what we know now is that when the HA is in the arterial system, it wants to shunt it across into the venous system to get rid of it. So this is where you see those delayed onset vascular occlusions. When you miss everything and everything looks cool, and then a day later they say, oh, it's really painful. You see libido and you're thinking, wow, there was no pain, there was no blanching. Again, it could be a little bit in the arterial system and it shunted it across into the venous system to try to eliminate it from the face. Very clever way to do it. But again, remember, it can go depending on the flow, up or down. So that's venous congestion. And again, the veins that you're looking at there is that middle zygomatic or the sentinel vein. You can normally see this runs pretty close to the eye here. So again, always tell your patients with that superficial technique that they're going to see the veins expand or dilate over the first 24 to 48 hours. Again, because of the lidocaine.
Right. Okay. Going back to the forehead now, we talked about different depths in the forehead. Can you give us a safer, I know the forehead is a high risk area and it's not something many nurses do, but I myself do some forehead contouring sometimes. I've used RHA2 with a cannula to create some nice contouring, but I've also seen techniques of needle down to periosteum. Both I think have advantages and disadvantages. Do you have any comments on that?
Yeah, so on for female contouring, you don't want this supraorbital bossing here. You can see my supraorbital bossing. So you're in this plane here, or in this position, sorry, on the forehead. And what you know here is that the vessels are superficial. So you can do a couple of things. One is you can just do 90-degree down onto the periosteum, around about 4 injections, and then milk the product across. Now you have to be careful over this lateral part close to the temporal fusion line here, because you have the deep supraorbital nerves here, and if you inject close to that, you're close to a little artery as well, and your patient will feel a big pain in the back of the head. So again, you want to be a little bit about a centimeter away and then just milk it across. So that's your typical periosteal injection. With a cannula, you can go a couple of ways. One, you can utilize the unique anatomy of the temple to pop through the temporal fusion line. So you're under layer 3 here. So you're in that avascular plane 4 with your cannula if you go through there. The same position is here centrally. Again, you have an aponeurosis here. So this is your layer 3. Once you're through here with your cannula and in through this position, again, you're utilizing the unique anatomy of the forehead and the temple to be in that safer plane. But remember how close all of the layers are here. So you will still see your cannula lifting up in this position. So don't be afraid. RHA2, remember you have that movement of the frontalis muscle. So your filler needs to respect that also.
Perfect. Now going to another area that you talked about in your presentation. Often as nurses, we don't treat this area, but when learning from Patrick Trevedick on approaching those glabellar lines and using RHA1, he just said, stretch the skin and use your needle very superficially perpendicular to the crease. I assume if you're going to approach that area ever, even though it's high risk, that is the best way to do it.
Yeah, I mean, it's high risk. As we discussed a little bit earlier, Barb, about the neuromodulator, then you stretch the skin. And what you really want to see is you do want to see the gray of your needle. You do want to see some of this filler coming out of the pores because you are that intradermal, and you will see the tissue just blanch up where you're going, and then you can just blend the rest in with your finger here. So again, it's not the number one area for blindness. It used to be. It's now this.
Yes. Absolutely. Moving down to the cheeks, we talk about this mid-cheek groove, and I think as nurses we see it coming in as a complaint often. Now we talk about this being a natural anatomical feature, and not trying to just completely obliterate it, but it isn't often a requested area to, I guess, correct a little bit. Your thoughts on approaching and the technique to use, and which product?
So your mid-cheek groove, which will run through here, again, it's a classical sign of aging, really, this sort of separation of the fat pads. What your real understanding here is this is where your depth comes into it, because you know that the facial vein is in that groove, but what depth is it at? So here it's below the SMAS, so it's in layer 4 into here, so it's in that deeper compartment. So here I would just grab the skin like this. So this is layers 3, 2, and 1. And I would inject RHA4 over that mid-cheek groove because I'm now above the facial vein. Okay, because I'm above the SMAS layer. How do I know? Because I've got everything in my fingers here. So anything that moves is subcutaneous fat. Okay. Easy.
Perfect. That's a great answer, and thank you for clarifying that. Moving on to the infraorbital foramen. Now there has been some discussion about how you approach it from which angle, which can create more safety or make it more of a risky injection. So can you elaborate on that a little bit?
So yeah, so the position 10 centimeters down, 26 from the lateral orbit, around sort of medial limbus of the pupil. Again, it's a lot higher than most people give credit for. People think it's down into this position. My background, we used to give lots of infraorbital blocks, and we had to go intraoral, and the needle tip was around about here. So it's a lot higher up. What I would say is don't go at this angle, because the infraorbital is like a little shelf, and you can easily go in. It's actually quite difficult to go onto the top here. So I just draw a vertical line, and I just inject lateral to this deep, because again, we know we have the superficial branch of the infraorbital in the superficial plane here, the zygomatic branch. So anything medial to the line, then you're going to go superficial, and anything deep. So the angle, not like this. I'm always a 90-degree straight down to the bone type of person, but not into this area here.
So coming across it, say if you're using a cannula safer than coming.
Yeah, cannula across. The other thing I do is targeted digital pressure. So I'll put my finger over the infraorbital, press it really hard down with my finger, and then work around here. Right. Again, I'm just making it really difficult for the filler to get inside of the vasculature. So targeted, your finger's great. So many uses.
Thank you. Thank you for elaborating on that. Now I have a question here. It says, how about injecting deep medial fat pad with ultra deep?
Yeah. Perfect. So deep medial fat pad is around about sort of the alar here onto the maxilla. Again, you can just draw the alar crease across, and this is where it is. And what we know from the literature, we spoke about, and I've said it a couple of times, surface volume coefficient and how much translation you have from the filler to the skin. We know that the SOOF, the medial SOOF, gives you the most bang for your buck. The deep medial cheek fat gives you the least bang for your buck. It's around about a 25 to 30% lift. Here you get a 95% lift. So that lends you to think about thinking, I'm going to have to use more product or something which gives big projection. So high G prime, high cohesive. And that's the reason why you would use, very correctly, as you've mentioned, ultra deep in that deep medial cheek fat, because of the surface volume coefficient and the need to project forward. Great question.
Perfect, thank you. That's all the questions I'm seeing coming in today. I think you've really clarified those for us, so thank you for that, Lee. Is there anything else you wanted to cover as far as the polls go, or any closing statements before we head out?
It would be interesting if we quickly put a poll up, wouldn't it, again?
Yeah, let's just quickly review that, if you can put that on the screen. Or
so it'd be interesting now with what you know, if the people who are still watching, again, just enter now based on your anatomical knowledge. Would it change? Would it be the same? Or, I don't know, is the jury out? Be interesting to see if we get any of these questions coming back, especially in the temple. Be interesting.
Yeah, the temple's an interesting one. Also, the lateral cheek is, as nurse injectors, is one of the first areas we learn also, because they say it typically is a safer area to inject. Now, I know myself in the past and other injectors I've spoken to typically get usually a bruise around this point here. If you were talking about CK1, CK2, it's kind of that most anterior point of CK1. But now I'm thinking about those foramen there, and that those exits of those arteries. Now, do you think we're just perforating as we're going through down to periosteum, or are we, getting pretty risky with this little point here?
I think you've got to think of a couple of things here, Barb. It's not just the zygomaticofacial coming out of this position here. It's the zygomatical orbital, and it's also the zygomatic branch of the infraorbital. Mm-hmm. When people tell you that there's nothing really important around there, then you've got to go back to the cadaver lab, or back to medical school, or back to anatomical lessons, to understand that there's a vessel everywhere. It's the significance of the vessel that you hit. So again, it's incredibly important to understand that you must maintain your vigilance at all time, not just because you're doing this and then just sticking a needle down. We know your target here is lateral SOOF. We know in the lateral SOOF runs through the zygomaticofacial. It's in the literature. Mm-hmm. And again, this is one of the first things I put on, was understanding how and why to do things. It's not just how to do it. Mm-hmm. Tell me where to put it and how much to put in. And it's a lazy person's way to do it. A very clever way to do it, but a very lazy way to do it. Right. Okay, so I think we've seen a shift in the piriform fossa, which I'm more than happy with now, because again, showing those anatomical publications and the evidence based around, again, maybe there's a shift. Yeah, there's been a shift in most things for the better, which is great. So peripheral neuropathy, I've never experienced a nerve. The only time I have is with a neuromodulator injection here into the zygomatico temporal. Again, a little bit of paresthesia. Venous congestion, yeah, they all understand it now. So yeah, it looks like, Bob, that our job's been done. It looks like there's been a shift with everything. So fabulous.
I agree. I even, every time I hear you speak and attend one of your sessions, I feel like I always learn so much more. You're such a great speaker, and how you present really sticks with you. So thank you for that. Thank you for the summary on how to treat vascular occlusions, and that quick little step-by-step. I think often in times of stress, we might lose a bit of our concentration. So I think just taking a look at this this step-by-step approach when we're calm and collected before we go into our day is a nice way to always remind ourselves on how to treat these things, because you see them a lot and you're definitely the pro to go to if these things come up.
Yeah, you know, do you ever need any help, advice? And this is for everyone. Marina knows this because we've helped with a couple of cases in Canada. If you have any problems, worries, or concerns, then I'm very happy to help support you through the whole process. So you're not alone with this. It's a very difficult time for both the patient and yourself. So I'm here for you. Again, just to continue your journey, your professional development, I'll be here as long as you want me.
Perfect. Thank you so much. So I want to thank everybody today for attending on this beautiful Sunday afternoon. I want to thank Clarion for hosting this and helping us continue to become better injectors. And Lee, thank you again for being with us and giving us this, sharing your wealth of knowledge.
Okay. Just a really nice comment there. Dr. Walker's now bumped Posh Spice off my favorite list of UK people. Listen, my job's done. I've got to go to bed happy. Thank you very much for that.
Perfect. Thank you so much and have a great Sunday, everybody.
Okay. Take care, everyone. Thanks, Clarion. Thanks for all the delegates. I really appreciate your time. Thank you.
Thank you.
Bye.